Here we are. Welcome to London, guys. Welcome to London.
Thank you very much for this opportunity to speak from Lorenzo. He's given me the most unsexy topic of all, thank you. But pretty much if he asks me, I'll say yes, present anything. From a personal point of view, this talk took on an entirely new level of poignancy for me very recently. And I think what I have to do is start by saying that it's really only just been a week ago since I heard the tragic news that my good friend and mentor, Mr. James Brown, one of the vascular consultants from Southend, had tragically been killed in an accident. And I think, you know, what I can say is that I learned from him is very much this topic on how to do amputations below the ankle well and the importance of doing it in an early, decisive way. But I also learned more generally about how you treat the people you work with and being yourself. And the registrars that we work with are really only colleagues waiting to catch up. And, you know, I think there'll be a lot of people who did know him and would say that, you know, for a fantastic, gentle guy that he is, he was also an excellent vascular surgeon. And, you know, we're going to miss him. One of the things that I did learn from him, one of the phrases that he coined, and I remember it very vividly, was take the toe, but save the leg. And there's nothing that I have learned in the 5 years since I was appointed as a consultant that has made me change my mind on this. And, you know, I hopefully will see that as we go through. It is a fact of what we do that we are going to get some of these patients too late. It's a fact that we are not going to be able to reverse the damage that has already occurred as a result of infection, most of the time with an underlying degree of PAD, whether that is micro or macrovascular. So in order for us to prevent the most extreme way, death from sepsis and ascending cellulitis, the way that we can try and salvage as much as possible the function after definitively dealing with this is to intervene quickly and decisively, as I've said. And there's nothing wrong with a more minor amputation that can heal well in terms of their ongoing function and quality of life. But let's make sure we understand the terminology. When we're talking about minor amputation, what we're talking about really is below the ankle. We start with the digital amputation or partial digital amputation. We move more proximally across the metatarsal heads to the transmetatarsal amputation. More proximal still, at the base of the metatarsals, really now at the lisfranc amputation, relieving the carpal bones intact. And then more proximal still through the chopart joint, the talar calcaneal complex. So take a toe, save a leg. It wouldn't surprise you to hear that the majority of minor amputations really are digital amputations or partial digital amputations. And there's a bit of a variation across the country, but by and large, it's fair to say that the vast majority of amputations are minor amputations, thankfully, and not major. But there's a bit of a regional difference. This photo in the bottom left-hand corner is an example of a chopart amputation. And while it looks horrific, that lady walked into clinic and she walked out again. So there is, as I say, a merit for that. When we look at the comparison between major and minor, but also diabetic, which is here on the left, and non-diabetic, and although this data is a little old now, isn't there a huge difference in the pattern or the temporal relationship between the two? When we look specifically at diabetics, and this is a little bit more up-to-date, this data, this is expressed as a result of the directly standardized rate, so this is a rate per 10,000 diabetics. We see that that incident is increasing. This is going up year on year. This is of minor amputation. When we compare that to major amputation over the same time period, it's largely plateaued. So an increase in the minor amputation rate whilst maintaining a reasonably steady major amputation rate. Take a toe, save the leg. What are the consequences of below the ankle amputation? Is it just something that we can do and there's nothing really in it for the patients involved? Well, this was an interesting study from 2022 that looked at primarily the hospital episode statistics of a huge number of patients, 22,000 patients over a 5-year period between 2014 and 2018. Overwhelming majority, nearly 85% were diabetic. This is no surprise. But what was interesting is that there was nearly an 11% ipsilateral major amputation rate. So it's clear that a large proportion of these seemingly innocuous minor amputations are going to go on relatively quickly to progress to major amputation.
We're amputating people that don't have enough vasculature, thinking, oh, maybe it will be enough, and then it's not. And then if things come too badly at some stage that you need to amputate the leg, could it be the reason?
So that's a very interesting thought, and there are certainly risk factors identified for those that would progress. And these aren't all people that were in the same hospital episode and that sort of idea of ascending podiatry where we just keep going and going until we do the major amputation. No, these were actually over the entire year period. But certainly the risk factors associated that were emergency admission, so those people that are presenting generally as crash landers, those that present with gangrene rather than infection per se. So that very much separates out more, we'd think, the microvascular or the major arterial populations. And also those that in the initial amputation underwent more drastic below the ankle amputations. So the ones that were through the transmetatarsals were the ones that were associated with a much higher risk of progression to major amputation. So yeah, it's a very clear population, and I think you're right, it's more the vascular than the diabetic per se. What was also quite alarming was that there was a 17.2% one-year mortality. And I think largely the same sort of populations and the same sort of patient that you're imagining. Half of them were dead in 5 years. And this is minor amputations, remember. So part of the title that you set me was talk about guidelines. And I actually thought or seen any guidelines on this, but let me look into it. So I went through ESVS, I went through SVS, I went through our own vascular society, I went through all of the various consensus documents, global guidelines. Couldn't find anything on minor amputation. Sorry, Lorenzo.
No, but that's a fantastic thought. I mean, we don't have guidelines for something that happens every week in every theater. Because I mean, come on, the vascular surgeon, at least one amputation you have done. You can say, I didn't do a transcollateral, but you have done a minor amputation for sure. I think in a year you do at least 10. So essentially, there are no guidelines to guide us through this, and I think it's a miss.
Yeah. So, in the spirit of find your algorithm, I thought I would talk about my algorithm. So, why are we doing it? What are the indications for the below the ankle amputation? What is the reason? Well, at least 4 of those top 5 reasons I could come up with are related to infection, and that shouldn't be a surprise. And at least the top 3, I would have thought, are emergencies. These are things that we're not waiting for. I think it's a grey area when it comes to dry gangrene because this really is considered to be infection in waiting. So I don't think there's anything too controversial in there. I'd be happy to be interrupted if anyone can disagree with me. No? Okay.
Because at our center we have orthopedic surgeons in our diabetic unit, and before we had a resident orthopedic surgeon, we always did an amputation when you had an open joint. But it changed that, and actually, if you have a good revascularized patient, sometimes you can save some fingers, some toes, of course, even if they have an exposed joint. So open joint, I will take that out of the list.
Okay. I think largely what we were looking at here is a sort of population whereby it might be the interphalangeal joint or the DIP joint, and that is there's open, you've got leaking of all sorts of joint fluids. You are looking at constant movement in that joint, lack of stability, irrespective of the integrity of the blood supply. And what you are dealing with is course after course after course of antibiotics because of repeat and recurrent infections. In those situations where you're dealing with bigger joints, for instance, the transmetatarsal phalangeal joint, I think you can actually excise the joint and actually preserve the toe. But are you really going to do that for a random distal tip of the fourth toe in reality? So don't forget that, part of the problem is the ongoing need for presentation to the hospital, the ongoing need for antibiotics. They all come within the context of that population we just saw that are probably going to be dead in a year or...
Martin Malina?
Sorry, the dry gangrene.
Yes.
Is there any evidence for it being indicated to amputate that? Because you will create a surgical wound more proximally on the foot, and because there is gangrene, there obviously was poor blood flow, and there is then no guarantee that that will heal, while I think that very many dry gangrenes actually don't get infected, and just simply nature finds the demarcation line, no?
Well, I think it's fair to say that in our experience, you're largely right, and we were looking for is for it to be fully demarcated, so we understand the joint, the level of where the demarcation occurs. But when you're looking at perhaps a full thickness dry gangrene of the hallux that really isn't going to auto-amputate, then you then get into all sorts of issues in terms of needing for dressings. The risk of infection is always there. You said that you think the majority don't get infected, but a sizable proportion still do. And definitively managing it ultimately ends up, I think, in either amputation or auto-amputation. So if there is optimally revascularized area, or in the case of people that have had treated infections that have been subsequently demarcated, by removing the dead digit, hopefully you're drawing a line under the problem, as long as it's going to heal, and that's the problem.
Mark, thank you very much for addressing this important and often unspoken about topic. I think one of the problems is that we don't plan ahead when we do the amputation. So just taking you to this photo that we put it here, when you do the amputation, when you take just the middle 3 toes, the lateral 4 toes, or a TMA, because what will happen is that when you destabilize the connection between the heads of the metatarsal, you get a shift of pressure, and then you create other pressure points. So
Beautifully put, covered in a few slides later on. But I agree with you.
Let's
Put it to the group then. What level of amputation are we going to do for this poor sod?
So it is like a 3 toes amputation, red flag, and metatarsal amputation, green flag.
I think the green flags win that, and I think I would agree, and I think that's what we did. And I'll explain why in a minute as we move on. So in terms of me, apologize.
A short question, please. Yeah. I agree with you with the medical treatment, but the question is, how long would you treat medically the osteomyelitis?
I'm sorry, please repeat the question.
How long would you treat with antibiotics the osteomyelitis?
I think what's reasonable is, we have a protocol within our unit where typically our treatment for underlying osteomyelitis or a concern of there being underlying osteomyelitis, even if they are sample negative, with exposed joints, for instance, or bone that probes to the air, would be around 6 weeks. So if we've done one course on the basis of sensitivities that were taken at some point in that patient's journey and they fail to heal, and then we have subsequently, either through toe pressures or other estimation of their perfusion, established that we think it's optimized, then a failure of medical therapy after one course, perhaps, we give the patient a choice of a second-line course of antibiotics, and that you're now looking at 12 weeks of treatment. By the time we're on to 12 weeks post-initiation of first course of antibiotics without healing...
Can I just ask one provocative question? For those who don't have a podiatric in your place, who is performing the amputation? Red flag, the senior guy in the house? Green flag, the first-year fellow or the student?
Don't lie. Don't
Yellow,
lie.
whoever is there.
The fellow.
So this is the sad reality. Okay, go
I
ahead.
think it's a very good point, well made. And I think it just reflects we're no different either, are we?
But the NICE guidelines are saying that a consultant should always be available. This is something like it's written
It's
there
certainly
in the
true of
guide-
major amputation.
Only for major, not for
Yeah.
minor? Okay, sorry.
So if they've got intact vasculature, usually foot and ankle surgeons, part of the team in the NHS would perform it. But if they've got compromised blood supply and they need revascularization, usually the vascular guys would do it, in our unit at least.
Yeah.
What about Italy, Gianmarco? Who does that?
Actually, we do the amputation by ourselves, but your point was completely, no, August's point was great. So we leave just the young people do that. So we have to teach them, especially for a typical amputation. But again, if we start for the wound stone concept, then I think we can go for more atypical amputation. If we don't go for that, then it's time just for transmetatarsal amputation.
I think this is a very important point. In our institution, I come in at midnight to do even a toe amputation, even if there was a senior resident in our hospital. Because we believe that this requires a senior person who is a specialist in diabetic limb salvage to do the procedure. So we don't leave it to our residents to do the minor amputations here.
Can I ask, is that for the procedure itself, or is that because of the decision-making required?
Decision-making.
Yeah, I would agree with you on that. Okay, for the benefits of time, I'm going to fast forward a little bit, but essentially as my algorithm would proceed, sepsis source control is #1 priority for us. Now, I know that you and I have spoken about this in past and other congresses about the timing of when the revascularization stage occurs, whether it's the same time or whether or not it's after the sepsis source control procedure. But I think if you're dealing with wet gangrene, or like we all affectionately think of a bag of pus, what a take-home message from me is don't wait for the plasty, let out the nasty. Okay?
Is this from Shakespeare or? It sounds quite well.
Sounds like it should be, doesn't it? Right, so I'm going to fast forward a little bit. We really, as I've said, try to aim to prevent higher level amputation, but as much as possible preserve function. But don't forget the point of why you're doing it. You're doing it to help prevent the progression and, of course, to optimize the healing potential. So my tips for the last 30 seconds are, where possible, try to aim for soft tissue flaps. But again, don't forget, aggressive debridement of dead and infected material is your priority. Think about foot length. And again, this comes back to your point, which was, why is it important? Well, this study I think was brilliant, actually, looking at motion capture analysis in healthy and in TMA amputated volunteers. And basically, I'll give you the highlights. By amputating more proximal to the metatarsal heads, the ankle is completely now taken out of the locomotive propulsive motion. So normally you've got the heel strike, you've got the roll and push off of the toe. If you do a TMA, then your ankle is essentially functionally fixed and the entire propulsive movement for a forward step comes from your hip. So it's a much more energy demanding step now than what you would have had during normal physiology. What we know is that by amputation of the lesser toes, particularly if you can leave the base of the proximal phalanx, there is minimal disturbance to this mechanism, this locomotive mechanism. However, amputation of the hallux definitely destabilizes the foot, and hopefully the next slide will explain kind of what I mean with this. It definitely shifts the axis of the moment of the pressure as you walk from what is essentially and functionally the head of metatarsal head of the second toe, shifts it lateral to the third toe. And this is very much now why you start seeing these areas of abnormal pressure and subsequent ulceration. If not, then progression to a Charcot's deformity with the amputation of the hallux. Now, I'll put this in for our Italian friends. We want to pay, tribute to their architecture.
The Romans.
The Romans, indeed. But think about the foot like a Roman arch. The keystone is identified as the base of the second metatarsal. This changes with more distal amputation, resulting, as I say, in destabilization of this delicately and precariously balanced effect, particularly when you're removing the tendinous support of things such as the extensor hallucis longus and brevis. And it results in that destabilization of the midfoot and subsequent progression to Charcot deformities. I don't think I've got any time to talk about tips and tricks. I'm happy to talk about this either in person or by all means another time. But
at dinner, it's a classic thing for
indeed.
dinner.
Oh, exactly, yeah. It's very, very good at parties. But essentially, what I want you to take home is soft tissue is your friend. Try and preserve as much as possible. I always favor the circular incision, something I very much learned from James, which is the microtoectomy. As much as possible, try to avoid destructive and, ray amputations, which is classically taught. The same with transmetatarsals. Treat them like major amputations, which is minimal tissue handling, minimal use of diathermy, where possible, use the longer posterior flap, not just for reasons of vascularity, but also because it is a weight-bearing surface and therefore more suitable for its new role as the primary weight-bearing surface. And then there is the contentious issue of primary versus delayed primary or secondary closure. And I think on that note, I would say that there are arguments to and for both, and I'll be interested in your comments. Thank you.
Thank you so much. Thank you so much, Mark. I think this is, as we said, you know, we just gave 20 minutes to this, but this would be like, we could spend an entire evening talking about this, because you know, we can go through cases, you know, like this case, like should I leave, you know, we didn't even talk about like if you remove the fourth toe, you leave just the hallux. That's another thing that we didn't touch. So I think this Congress is also a matter of understanding and trying to push you to investigate, to improve our practices. And I think this was great, Mark, and I thank you so much for that.
All the faculty.